Dr. Vale doesn't require any introduction to this audience, especially the informed audience, the junior members. He has presented to us many times, and this is an innovation he had suggested, and let us see how he does it. And I found it very, reasonable. The way the exit site, how it is turned down, so the chances of infection is less. So let us look at his demonstration, then we'll discuss. Yes, Dr. Vale.
Yes, sir. Yes, sir. Can I start, sir?
Yes.
Yeah. Okay. But you gave a nice heading, sir. For you can't beat, you can bend it. It's not a new one, sir, because it's already there for quite some time. Just I started using one or twice, and then it became very fast. It's very useful to very poor patients in that case. And fairly, I've been using for 1 year, and it's lasting for more than 3 to 4 months. It's as good as the cuffed catheters. So these are some. So my slides are visible or not, right?
Yes. They're visible.
Just I have some issues here. Okay, I'll go with this. Okay, so the next few slides will be about general things. And we have two types of catheters: non-cuff straight one, and the other semi-permanent cuff catheter, like a stagger tip, that is known as step-in or shotgun, split and symmetrical. The other modifications of semi-permanent self-centering curl tip and stylet preloaded as a glide path. So this is about recirculation. As far as I learned, and there is a less with the palindrome catheter. So this is about catheters we have right now in our country. If we have a straight non-cuffed, the 12 French, 13 centimeter and then 15 centimeter, which is about, and the another one is 11.5, which is 13 and again 15 centimeter. And today we have, I'm going to talk on only the pre-cuff, non-cuff. What I am using is a 12 French and 16 centimeter. The right side TCC and left side TCC, they are known to you, and all the participants of our today's meet. So I'm just focusing on only pre-cuffed, non-cuffed catheter. Tunnel catheters available in a larger size, but in non-tunnel catheters, largest one we have in our country is 12, and as big as you can 13.5 one can get it in other countries, not in our country. It's 12 French. What I'm going to describe today is a 12 French 16 centimeter catheter. So I'm just going to show you step-by-step insertion of pre-cuffed double lumen catheter. So we have a 3-point at hand. It's a probe, piercing point, the position of the tip. This is the 3 P's we always adapt when we do a DLC. Generally, I don't use probe. If I prick 2 times, it failed, then I'll go with the probe. Generally, just traversing from the early 2000 to now. So the time I find that my blind technique is as good as one. If I fail in 2 times, I'll definitely use the probe. So in the approach I'm using, posterior approach, generally the probe will not give much delineation about the vein course, but anyhow, just I'll show you the piercing point and position of the tip. This is all approach based on a skin surface marking. So this is the 2 technique. One is the first approach, the supraclavicular. You need not stand at the head end of the patient. You can stand on the right side of the patient, and you can start approaching a 45-degree angle to the nipple, opposite the nipple. This is the first technique. This is the one generally I'm using last 1 decade or so. My senior technician is following my suit, and she's doing a lot of temporary catheter on this approach. If an ICU people, if they wanted to go this approach, they can use it for a central line catheter and slightly tilted angle. This is the next picture, right picture. That one is not is my cup of tea. That's what the first one I'm doing routinely. I never do an anterior approach. Ever since I came here, last 20 years, I just doing only the posterior approach, supraclavicular approach. So this is a striking point. If I stand on the right of the patient, if I prick from them, that angle is like below clavicle, above at the lateral head of the sternocleidomastoid, and behind you have a external jugular vein. Exactly the angle in the middle, you prick and you will get the vein. You hit the vein. So it can hit the in IJV or subclavian or junction of the IJV and subclavian. So this is what my assumption is all. But if you tilt 45-degree angle and go towards the nipple, generally you will not fail. So many times we succeed. Occasionally we'll make prick a subclavian artery, but we can change the course. We can get success after the subsequent try. So this is what just the diagram I drew for the audience. Right, I'm standing on the right side. The head end is the foot end. There is a medial head of the sternocleidomastoid. Right, this lateral head. Down is a clavicle. It's external jugular vein, exactly middle. Opposite 45-degree angle. Just you go, you'll get only the vein. Either you could hit the IJV or subclavian or junction. So this is a rib. Generally, we don't, in our unit, I have only the X-ray static X-ray machine. We don't have fluoroscopy or CM. So mine is a standalone dialysis center. Right? If I take my patients somewhere, then it's a tedious job for me. So generally, I tune to this kind of approach of skin surface marking, and generally I succeed. And the first rib, what you palpable is the Lewis angle. And first rib always getting attached to posterior sternocleidomastoid or sterno and clavicular-sternal joint. So you cannot palpate the sternal. I mean, first costochondral rib. What you first feel is the second costochondral. It's a Lewis angle. Then subsequently come down. So from fourth intercostal space, exactly lower part of the fourth intercostal space is the nipple. That exactly points towards the mid atrium, right atrium. This way we go. And by experience, this time this okay, this okay. I'm just going through. This I'll skip for the reason. Okay. Okay. Right. Position of the tip, as I said, in the fourth intercostal space, roughly it corresponds to the middle of the right atrium. And this is a model patient. I took all the images and videos from 2 days ago. So generally, we put pre-covered catheter in a majority of patients. In some patients, since we allowed some entry of other company also to be in our pharmacy, so we just to completion sake we use other brands, but generally we prefer the pre-covered one. And this is the way I count ribs, and I first pre-map the area, surface area, and where you if you go in the anterior approach, probably this pre-marking may not be compatible with your after the procedure. It may change, some kind of up and down position may be changed. But this in this approach, what you exactly draw on the skin, you will exactly see in the image, and I mean the X-ray position also. So this is something I'm using, and I'm just pricking while sitting on the right side of the patient. I just pathfinder needle and just so this is all position for the time, paucity of time. Okay, now this is okay. Now I'm using the Sheldon needle. Manipulation is enough, and mostly you succeed. I just go with the gentle push technique. Put a guide wire, then make a nick. I just use the dilator just provided in the kit for making a tunnel. So, or I use artery mosquito or straight artery forces. Then I dilate the vein over the guide wire. Then I keep the dilator in situ because I'm going single-handedly, so I just not avoid any bleeding from that dilated vein. I just keep the dilator in situ. Then I push the pre-covered catheter through the tunnel, or you can use the artery forces. You can pull it, or you make the tunnel little patulous and can pull it just like that. You can push it; it will come on the other end. There are a lot of things. If I show, you can make a lot of innovation on your own. But this is the general thing I follow. And so once you video. I just where sometimes I found initially trouble because this guide wire is not that good, to slide through your venous outlet. So sometimes it may get stuck. You have to pull your force. But what I do, I just once the guide wire comes out, and then you push the catheter till it's all the full data goes inside and it becomes straight, and a nice curvature comes. Pushing. This is a slightly difficult, but once the curve is normal, now we can pull the guide wire easily. So yes, I'm showing how the guide wire is coming very nicely. And after the procedure, this looks like exactly like a normal curved catheter. And now you see the position. So I just check the blood flow. I generally see the gush of blood, not just a simple flow. Gush should, we make a 10 ml. Just here I use a 5 ml syringe, but you get 10 ml, you just suck it, it will come very freely, which corresponds to the good, uh, flow during dialysis. So this is another end. I just soon after that, I took X-ray. Exactly the position you count. This is surface marking for whatever you make in the beginning on the skin, which will fit exactly in the X-ray image. And first strip is because this is the AP view. It's not a PA view. It's a AP view. You have to count the first palpable rib is the second costal cartilage, which is a Lewis angle, and third costal cartilage is the caveatrial junction, and fourth, the intercostal space are just above the fifth upper border is the nipple area where your exactly tip will be in the right atrium. So most of the time we never go into the theater and to use all these things. And this, of course, we had a little lower down, little higher up, and over the time we adjusted. And now last few years we never we just took a X-ray after the procedure, and to our satisfaction, it is in the tip is in the right mid-atrium. So different patient. This is another patient, right? You know, we put catheter routine few days ago. This again, just to show the position, I took this X-ray. It's a different patient. So 35 days old, pre-curve DLC, flow is adequate, exercise normal, easy. It's very easy to maintain. When the temporary catheter is projecting, jutting out from the anterior to the near the behind the ear something. So putting a dressing is sometimes difficult, and patient maybe it's socially they may be prohibitive to visit outside. So if you, this is a very, it's hidden inside the shirt, and you can dress it. Even patients can watch their exit site, and they can immediately report to us. And but the only thing is, and the wing where you are taking stay switcher should there for a long time, otherwise smell. But a few patients we removed it because of it curve itself act as a hindrance to accident is coming out. So we find it extremely useful, this catheter. And this is a different patient I just show you. And this is the one area, one point everybody finds difficult. So just make it like this, and put a guide wire. So here I didn't put the dilator. This is a technique I used many months ago. Now I put a dilator in situ so that to avoid the blood gushing back from the dilated vein. And once I put it, so just to, so the cost of the catheter, the price to the retail, what you call the PTR, it's a 2,744. That's what they supply to our pharmacy, and the MRP is about 5,300. It's up to you to how much you charge for your patients, everything. But any poor patients, I think in my priorities, we are doing a lot of kidney transplants. For down the line, 3 months they go for a transplant. We don't create AV fistula. In some certain patients, there is some delay in processing the donor. We create a AV fistula, or else we just keep this catheter for a few months, 1 or 2 months till they undergo transplant. Just prior to transplant, if they don't show any kind of exit infection, tunnel infection, or no episodes of fever, I'll take them through the transplant. This catheter, as I pull out, I put in one more catheter inside the theater. So thanks, sir. Hope this is a old wine in a new bottle. Nothing new, but some kind of new innovation. I don't flex muscles. New summer. It's just showing a new technique for the new people who are finding their feet. So probably it may be useful. It's a food for thought. One can try.
Yeah, thank you. The only step which looks, you don't have a tunneler. So is it always easy to push the catheter from down up?
Yes, sir.
As
if you do few catheters, sir, we know that, but the tricks and trade of all these things. You can use that the small dilated tip, and you can pull it, or can use mosquito forces, or you can, if you had really preserved some dilators of the tunnel dialysis catheter, the trocar, then you can use it and pull it out. So there are so many ways you can do it, but most of the time when you make a dilation through the artery forces, it will come out quickly, sir, because the distance, the traversing distance is not long.
I think it's only a short, short tunnel. It's not a lengthy tunnel as we do in tunnel catheter. I think
I'm-
auditory forceps will easily go through and
Straight auditory forceps, not one straight auditory forceps will be good, and mosquito, sharp end mosquito, a good quality one, and so that it not damage the tissue. And we don't find any issues with this, and I'm just quite comfortable with this. And
still, I'm worried about this guide wire coming out.
Initially I found difficult, but off late, and it's become once push the cow entirely in the second the entry point, the piercing point, where you make the small nick become little larger, so you can
You
manipulate.
have a bigger nick, right? So
yeah, if you put that's rightly you point out. Earlier I used to make a very small nick, then I put it now 1 inch, so that you can suture it later and you can manipulate in that area. This was suggested by one of my colleagues here.
yeah,
So
that entry point should be bigger, like what we do in
exactly. And it become quite deep.
Yes.
Bala, Hemant here.
Yes, Hemant.
Yeah. So
What are your thoughts?
No. Let me tell you something. I don't know how many people on this platform knows Dr. Robert Uldal, affectionately called Bob Uldal, from Toronto General Hospital. So in the 80s, he was the first person to advocate this WMN catheters in the subclavian vein. And even in those days, he used to make a tunnel in the subclavian vein. And I was fortunate enough to have learned this technique under him by him holding my hand. Okay, that much. So I started my career putting subclavian. And remember, I'm talking about 1988, where in India, the concept of jugular WMN catheter did not exist. It came about a year or two later. So WMN subclavian catheter, and it so happened that we had 2 Terimo catheters lying in my boss's cupboard, which I happened to see it once accidentally. And then we did our study, and then when he was coming, so we requested him to come to our department. He did first, and then he asked our boss to ask somebody to wash up, and I was lucky enough to be chosen among half a dozen residents to learn the technique. We started doing it that way. It was a 19 centimeter catheter even in those days for a subclavian non-cuffed tunnel catheter. I just want to bring this part of the history. I don't think everybody knows about it. So Robert Uldal unfortunately died at a premature age in 1995. But he was, even in those days, when nobody knew what is vascular access, he was the vascular access man. He did not practice anything else, only vascular access. That's what the history says. So that is one part. Second, nice innovation on your part, but let me tell you just one thing. You are still not preserving the central vein. This is a stiff catheter. So at the end of the day, you will still end up causing all sorts of complications which will occur with a stiff catheter compared to a soft catheter, which are relatively supposed. Yeah. And thirdly, when you say that you take the patient up to transplant with this catheter, let's not forget about both biofilm formation and catheter colonization. So why not change over about a week earlier rather than wait till the end?
We do it, sir. We do it. We look at 3 points, sir: exit infection, tunnel infection, and fever after 1 hour.
If there is no infection, colonization would be there.
Even otherwise. Yeah, we can sacrifice when the cost is less. We can do it, sir. No, I take your point, sir.
Yeah. Thank you.
So, Well, I heard, you said, I like this. We don't use the pre-curved aldol, but we do have soft dialysis catheters. And what I have been doing is, like you mentioned, instead of sticking it up in the neck, I bring it out onto the chest. So it looks like exactly what you're doing. The only thing is I don't have a tunnel, but I bring it onto the chest so that the patient, it doesn't stick out, like you were mentioned, as you just said, behind the ear. And you can do this with the soft catheters. And many times people have thought I put a tunnel dialysis catheter because, there's a dressing covering the catheter. But that's what I've been doing. And the patients love it when I just put it onto the chest.
Adrian, the main advantage point in this procedure, I thought, was the down-looking exit point.
Yes, I agree.
PD, we say,
Yeah, I don't have that. Mine is still up here in the neck. Yeah. It's just sutured up down here. Yeah. Because it's a soft silicone catheter, it can bend. It does the job beautifully.
I haven't used this procedure much, but I find a lot of advantage. So technically, if it is
A
fixed,
lot
I
of
think it
poor
should.
patients are coming. There's quite a lot of poor patients. My city is drained by a lot of villages. They come with 1,000-2,000 rupees money, and I find it so useful to the people at least to initiate the dialysis. I'll give them some kind of, because when the patient entered the hospital, the initial cost alone scare them a lot, sir. So we just put them in a, then they slowly understand the benefit of dialysis. Then they'll agree to come for regular dialysis. Then I do free of cost or 50% concession the fistula, because we are doing a one-man show, sir. We do this thing and the fistula and take them to a transplant. So it's kind of incentive for patient, nothing else.
Right.
Dr. Subramaniam, this is great, very innovative. Do you know what's the average number of days you keep the catheter in? Because like Adrian mentioned, at least in the US, we don't leave the non-tunnel catheter beyond 7-10 days at the most. Patients don't go home with that catheter for sure.
Yeah.
And I think this technique, what you're showing, if you are familiar with the PICC line, Bard actually makes those PICC lines, and PICC lines don't have a cuff, and they're recommending to use that PICC line as a small bore tunnel line in the IJ in patients where we try to preserve peripheral vessels. So you're using, if it's a softer catheter, definitely this is something worth looking into, as it cuts down the cost significantly. It's much more comfortable for the patient. But I don't know, the downside being, with this technique, you are very close to subclavian, so the risk of subclavian stenosis is higher. And if there is subclavian stenosis, obviously
I do TCC also, sir. I never go with the anterior approach. I always do tunnel dialysis catheter in this similar way, and I have cuffed one. And
have you seen any higher incidence of subclavian stenosis?
Nothing,
Or
nothing.
how long, on an average, you leave the patient?
9 months, 2 years. This catheter particularly extend up to 5 months. That's the longest patient I had, and I think we'll go on for some more time. As Simon said, we had to buy a film, other things, and I just pulled out. By the time we created a fistula and we switched over, but I yet to see a patient going beyond 5 months. So that's my upper limit.
Well, what do you think if you use routine anterior puncture in this technique? You think
there are some problems there, because even sir, if you use a blind technique, bedside technique without fluoroscopy or anything, if you go anterior, the sternocleidomastoid movement will pull the catheter a little bit up and down. It's kind of a positional change will be there. The tip position may not be ideal, sir. And moreover,
and you can get a better curve here, I think so. When you go posterior approach.
Last 13 to 14 years, I adopted this thing, and a really very good and useful one. Quickly, you can find it in a vein, and you can do it at the bedside. You can soon after you can start a dialysis. You would take X-ray, the tip will be in the right position, because you make a skin marking. It will go exactly similar way, sir.
Then Tushar,
you can still use the ultrasound for posterior approach.
But I find it difficult, sir, because some kind of trajectory changes will be there with that. Maybe I am not good at.
You should come and see our patients. Some of them are BMI of 65 and 70. How do you do? Where are the landmarks?
Yeah,
Actually, blind procedure takes less time. When you do, we'll be scary with the probe, right? But that is safety for the patient.
Yeah. So small.
And one more comment: the posterior approach, I think you will get a better curve than the anterior approach.
Yeah, very true. And of course,
And you always tend to go higher up.
Yeah, angulation will not be. That the sharp angle will not be there. Otherwise, we go to the higher up. You prick in the anterior approach, so you might go higher or below, and a lot of issues are there. But now we stop doing that first. Until otherwise, we find.
The point about the movement to the neck and the sternocleidomastoid, I mean the muscle, pulling, moving the catheter, I think that is true. Otherwise, anterior approach, that a disadvantage may be there. And Tushar, I intended to highlight this because when I was asked to talk on temporary catheters, what guidelines say. So I realized there is a lot of discrepancy between what guidelines say and what people practice. because I took a survey among practitioners about their usage of temporary catheters, and there were umpteen number of people who were telling, their first access is always temporary catheter, because most of the patients are crash landers, or they come straight without any preparation, and they were using it for much longer time comfortably and all that. So if not directly approving that, I thought, why not think of some innovations and some way where you can prolong the life of temporary catheters, and this sounded very reasonable for me because of the, I think at least if not anything else, the infection rate may be slightly lower than temporary jugular, and maybe we also know that subclavian catheters, the infection rate is less than in internal jugular because of the lie of the catheter. So this has the advantage of both. So I thought I'll show it to the people, and whether it will be approved by everybody is something different.
I think this experience needs to be properly studied and published. I mean, this definitely a great way to possibly reduce cost and infection both.
Yeah.
We completed 70 catheters then this way, 70.
Maybe you should look back on those patients and publish it if you have information, or if you can collect the data.
We can, I think we can start collecting from now onwards. That maybe we lost track of all those patients. Now we'll do it, sir.
See, Tushar, the problem is that none of these veins are ever studied and looked at for any evidence of central vein stenosis. Let's understand that. This catheter remains there till the fistula is done on the opposite side, hopefully, or the patient goes for transplant, or patient disappears. So we are never going to have, and mind you, these stiff catheters, so long as they are in place, mostly they work well because the vein which is stenosed is around the catheter and the catheter is stiff. So catheter will never collapse. The catheter will keep on working.
Right, very true.
Yeah, this is very unorthodox, so needs a lot of, I expect a lot of controversies, but I think people should know.
വേണമെന്നില്ല അത് തരാനൊന്നും പറ്റൂല ഈ ആവശ്യമില്ലാത്ത ചപ്പ ഞോറൊക്കെ കൊടുക്കുന്ന ശരി ഓക്കെ എന്നെ എത്ര
Dr. Bala, I have to leave.
Okay, thank you.
Right, thank you very much. Enjoyed meeting everyone.
Yes.
Dr. Bala, Dr. Chandra. All right.
Bye, Dr. Tushar.
Bye.
Okay.
Bye, Adrian. Bye.
Adrian and others, thank you, Tushar. I think we'll move on to, if there are any other discussions on any other issues, we'll spend a few minutes. We'll break.
Definitely, anytime. Yeah.
Okay.
Bye-bye.
Thank you. If there aren't any more discussion on these two topics, so I thought recently we've been, our forum was especially discussing very complicated things, and I thought let us go back to some mundane things like AV fistula cannulation and temporary catheters. I think it has served some purpose.
Yes.
And